Hi, welcome to these deliberations on integrated lectures, and myself, Dr. Prasan Vij, and I'm here to welcome esteemed faculty of Prep Ladder, Dr. Sonu Panwar. Hi, Sonu. How
Hi,
are you?
sir. I'm fine.
And
And
what is happening that we are going to discuss about a very interesting topic, Dr. Sonu. What is my everyday practice is that we see a woman who comes to the gynae clinic with something called a white discharge per vaginum. In fact, the interns are so fed up of this symptom that they have coined a very interesting acronym WDPV, white discharge PV, and I get very irritated when all they write is WDPV, and then after that they just give off a tablet for treatment, imagining that this is whatever diagnosis they feel is comfortable. So, what we're going to do today is that we're going to discuss that if a woman comes with a white discharge per vaginum, when we examine from there, what could be her diagnosis and give her appropriate treatment rather than giving a gunshot treatment of all the antibiotics put together, which actually happens in the prior practice and it's not a very healthy practice. So, we should treat symptom and diagnosis specifically. So yes, Dr. Sonu, whenever I see a case of white discharge per vaginum and I do a per vaginal examination and I see the characteristic of the discharge, so sometimes we see a discharge which is creamy and grayish in color and there is this fishy odor around it. So I'm almost certain that it is bacterial vaginosis. But in that bacterial vaginosis, apart from that, there's so many other criteria which could help us do a more specific diagnosis based on the symptoms and on the criteria which see in the lab. Could you help us with that so that the students understand that what is the best way to make a diagnosis of bacterial vaginosis based on the clinical symptoms and the lab criteria?
yes, sir. It's a very high yield topic also as per the
Exams,
exams.
definitely.
And,
Always an MCQ on this.
yeah, always an MCQs, and this time also, last time also, it was there.
Yeah.
And sir, this criteria must have heard of. That is the AMSELS criteria, and this particular AMSELS criteria is a favorite of examiner. I suppose must have suffered from this.
Yeah, we have. If you don't remember this, then they say that any 3 out of 5 or any whatever is the criteria, and if you don't know the 5, then which 3 do you mark? That's the problem.
So, sir, basically, as you have told up the features, clinical features and all, along with that, we focus upon regarding the pH, and pH is more than 4.5, and as you have told, it's more towards the.
See, it's generally we know the vaginal pH is acidic, so here it is pertaining towards alkalinity. Look, absolute alkalinity we all know means any pH more than 7, but the vagina is very comfortable at 4.5 and lesser. So if the pH shifts, now that's what you have to know. A shift in pH is enough to cause discomfort to the woman with such infections. So a pH of 5.5 is good enough to cause something like bacterial vaginosis. So it's not absolute alkalinity, but it is relative alkalinity to the normal pH.
Okay. And sir, regarding the color of the discharge, you told it's a grayish white or sometimes creamy also, sir?
Yeah, it is creamy and the color is grayish. The
Okay.
consistency is creamy and it's gray in color. Yes, correct.
Okay. And when we put the discharge into 10% KOH, then we say, sir, that fishy smell comes. And this you terms as which particular test? Like you also know the whiff test. We call
There's a
it.
whiff test. When we put this, there is this fishy odor, and after that, some amines are released. So ammonical odor,
Exactly.
and
Because of that,
yeah, especially patients will also come and give a symptom. I'm reminded that this fishy odor, of course, the KOH test will give the fishy odor, but we must remember that the patient will also complain of this, especially after intercourse. After coitus, this there is more of this fishy odor, and the patient actually comes and says the smell is like a very uncomfortable smell, and they are very distressed with that. So yes, rightly said, sir. Apart from that,
And the most important cells which are look out here, sir, these are like clue cells.
yeah.
And these clue cells, guys, this is like epithelial cells over which these particular Gardnerella vaginalis, which is the most common causative agent of bacterial vaginosis, that will sit upon.
Okay, so the periphery of the cell is crowded by these these cells, and we know, I mean, these bacteria, in fact. So the whole cell is the margins of the cell are blurred with this numerous amount of bacteria. So that gives us a clue. That's why it is called a clue cell, right?
Yeah,
It gives us a
exactly.
clue that Probably the patient has a bacteriogenosis. Apart from that, there's something about the leukocytes and the anaerobic bacteria. They keep asking me in the exam that all the of all the following are correct, which is not correct in the question they keep asking. So I think there are no leukocytes. I think
yeah. There is no leukocytes here, sir. And regarding those anaerobes, that Ganglion vaginalis is a sort of anaerobe, and along with that, those Prevotella and Mobiluncus. These are the
other anaerobes also. Okay, Prevotella and
Prevotella and Mobiluncus. They are the important ones which relate up with this particular bacterial vaginosis.
Right.
So this is what is termed as AMSA's criteria, so pH more than 4.5 and the greyish white discharge. And when you put 10% QH, the fishy smell comes, and this particular clue cells is diagnostic and frequently asked question. This particular one. Okay.
And in addition to that, what if I, as a clinician, of course, you are a whiz kid with the equipment and you can, see these things and you can tell us so nicely. But if I have to do something, fast forward types, easily diagnosing without, if a patient is in a hurry, I just want to take a sample and send for a test. And is there something smarter now apart from doing these bulky and cumbersome tests?
Sir, some card tests have also come.
The amine card test?
Yeah, exactly.
Yes. Is it used very frequently or it's on request?
So it's on request, I suppose. And more important, like nowadays, is this particular test also, the NAT.
Okay.
The nucleic acid amplification test. That will confirm up.
That will confirm. Okay, so that will be diagnostic. That okay, we can. And
so basically, it's another name of PCR, sir.
Okay, all right. Okay, so apart from this, what happens that when we see these, patients with white discharge, and I've taken the patient's discharge on a swab and I've put it on a slide. So this we also do we have in any gynae clinic. Along with the clinic, we have a small examination room where we do investigation, small attached lab. So where we can take this swab and plate some amount of discharge on a slide and dilute it with 1 or 2 drops of saline. It's called a saline prep. Okay. And under the microscope, a clinician can also come to at least a primitive or a presumptive diagnosis that there could be this infection. So sometimes I remember seeing in my PG so many times that when we do a saline prep in white discharge patients, sometimes I see these motile organisms, flagellates, I see them. Okay. So yes, we know that they are the Trichomonas. So Trichomonads, like you call them, or you call them the Trichomoniasis vaginalis, the parasite.
Yeah.
So these we see, the motile organisms, and this also helps us diagnose there as well that this could be trichomoniasis. Apart from that, how else we can diagnose trichomoniasis? We also have this, the white discharge, we generally call it white discharge, but there it looks like a greenish yellow frothy discharge.
Yeah, exactly.
The characters of that's what they say.
Sir, let me tell you something about Trichomonas vaginalis. This time it was a question in integrated fashion.
Was it? Okay.
Yeah. So basically, sir, Trichomonas vaginalis is a protozoa. Okay. Which does not have any cystic stage. So this was a question that name a protozoa which does not have a cystic stage.
So you mean to say it has only got the trophozoite
stage. And exactly that is what you are telling Trichomonads are.
Alright, that's called the trichomonad.
That is the trophozoite form of this particular organism, which are motile, and they have a very variable number of flagella. Okay, 5 to 10, in fact, they are there, and the flagella. Okay. And they're having a characteristic motility also. That name also is being asked, sir. Twitching motility. That you are telling
the motility, what it does, it causes a lot of irritation to the woman. And that's why one of the symptoms, because of these motile organisms moving all over the vagina, they will cause a lot of pruritus. Extensive pruritus is what the woman will complain to us. And these are known to, hide under the prepuce of the man. So after one act of sexual intercourse, almost 70% of the partners can catch this infection. That's how easily these trichomonads can transfer between partners. So yes, they will hide under the prepuce of the man, and if you treat only the woman, then there will be a recurrence. We'll come to the treatment later, but sir was telling us something more about the diagnosis, sir.
Sir, diagnosis, it is the same thing, like pH here also goes more than 4.5.
Again, the shift of pH.
Yeah. Same here happens. And as you will be knowing better, sir, that particular thing that is termed as colpitis macularis.
So yes, colpitis macularis. So Colpus is the Latin name for vagina, and colpitis means inflammation of the vagina. So we say vaginal inflammation making red macules all over the cervix. So yes, that is what is known as colpitis macularis, or in the regular terms, which you people know very well, as a strawberry vagina. So yes, when you see these red macules all over the vagina and the cervix, it should remind you of strawberry, but mind you, it does not really do that. But since it's been a very common asked question, so you must know that the Trichomonas vaginalis will give that strawberry vagina look, and there will be this greenish yellow frothy discharge. And now Dr. Sonu has said that again the pH is more than 4.5, so it's pertaining towards alkalinity. So I'd like to summarize a few things here. In bacterial vaginosis and in Trichomonas vaginalis, the pH is pertaining towards alkalinity, and both of these may have the whiff test because the pH is shared, and that's why the whiff test, which is characteristics of bacterial vaginosis, might also be seen in Trichomonas vaginalis. And one very important thing is that both can be treated by metronidazole. 500 milligram tablet given twice a day for 7 days is the dose given in the Western books. India, we have only the 400 milligram tablet. So I give 400 milligrams twice a day for 7 days, and it gives us excellent results.
And in this, like a partner is to also be treated enough?
In Trichomonas vaginalis, we will do that, but this is the distinction now. That's why Dr. Sonu has thankfully pointed that the sexual transmission is seen in Trichomonas vaginalis, but in bacterial vaginosis, there's no sexual transmission, and that's again a MCQ which has come many times. So going from this, sometimes do you want to add something else about this?
Yeah, sir. Like here also, if somebody asks you that what is the investigation of choice nowadays, like you have to go for NUT.
Is it? All right.
Like it's better to confirm if you are confused.
So in addition to seeing the trichomonads, the flagellates, motile flagellates, if we have this, we have a confirmatory diagnosis.
Confirmation. Basically, with this, the stuff will be there.
All right. So in addition to this, sometimes when we see a woman with white discharge, the diagnosis presents by itself. The strawberry vagina might come, but then another disease known as candidiasis comes with a curdy white vaginal discharge. That is so characteristic. When you see that cottage cheese kind of a discharge, then you know for sure that it is candidiasis. But then again, you would want to make a pakka diagnosis, a sure shot diagnosis. And in candidiasis, how do we come to the diagnosis, Dr. Sonu? Because there's a lot of talk about the hyphae or pseudo hyphae, and what is the reason for the adherence, and what is the reason for the toxins causing the itching. There's so much talk about candidiasis. So can you help us with the diagnosis, Dr. Sonu?
Sir, actually, like in that, initially we can prepare a wet mount also. In the this particular discharge we can take, and we can prepare a wet mount. In that, what you can see is, because we know Candida is a yeast-like stuff. Okay, it's a yeast-like stuff, and yeast-like means it can have a hyphal form also along with the yeast. And true yeast is cryptosa. This is a yeast-like.
Yeast-like. Okay.
This is yeast-like, and that's why we talk here about. Actually, in the microbiology, we say, sir, that if somebody asks you, this fungus which is having all the forms. This is the one which is having it. Okay. Sometimes it only presents with the yeast cells, so that is termed as true yeast stuff. Okay. Sometimes it's like with yeast, some hyphal form. Sometimes pseudo hyphae. Sometimes true hyphae. Means this can present up with all sorts of forms.
So is that
this particular Candida?
Is that Candida? The reason why I call it the dimorphic fungi?
Sir, this is like a controversial slight bit regarding dimorphic stuff. Okay. Because dimorphisms is basically, sir, related up to the temperature.
Okay. So it gets still more complicated.
Actually, that is related to temperature. Means yeast at 37 and 25 they are malts. That is hyphal form. Okay. But this does not show that particular thing at temperature change. So that's why we'll not keep it in the dimorphism stuff.
Okay. So we'll call it yeast-like, and it has got polymorphism. But
exactly. That is the word to use, polymorphism. It can be in the form of true also. It can be a true hyphal form also. It can be a pseudo hyphal form also.
So thank you, Dr. Sonu. That was very informative. So in addition to that, when we say that a patient has come with candidiasis, a patient with candidiasis can have complicated candidiasis and uncomplicated candidiasis. And yes, most women who get candidiasis, you must know that out of all women in the world, 75% women will have candidiasis once in their lifetime at least. And in fact, around 45% women will have it twice. So more than twice, that is. So candidiasis, when it comes, they women might be totally normal and have this fungal infection, and that is a uncomplicated candidiasis. It is easy to treat, and it is mostly by Candida albicans, and generally the one shot treatment is enough. But what happens in a case of a complicated candidiasis? It comes in women who are immunocompromised, women who are having probably HIV or tuberculosis, then pregnant women, women who are on long courses of antibiotics. So these are the women who will get complicated candidiasis. Now these are because of the
Candida albicans.
non-albicans species, yes, and like for example, I think
Candida tropicalis, glabrata,
and tropicalis.
Gullermondi, Vishwanathi, number of them they are coming off. And the problem of all, very rightly you have said, sir, like they mostly fellows, they are what? Multi-drug resistant.
Yeah, the problem is precisely
Resistance
that.
is increasing like anything in
So
them.
whatever we give them, they will come back with the symptoms. So the complicated candidiasis tends to become recurrent, and we call it recurrent candidiasis if we have the patient coming to us more than 4 to 6 times in a year, and they become very difficult to manage. So what we do for the treatment, that if it is uncomplicated candidiasis, just a single shot of fluconazole of 150 milligrams is mostly enough. And for a recurrent candidiasis, we'll have to give the fluconazole on an extended regime, that we may have to give it for 3 days, and then you'll have to repeat the course of candidiasis treatment, that is giving fluconazole at least once in a week for almost 6 months. So you'll have to give a long-term treatment with fluconazole. But having said that, candidiasis per se, the treatment is better by the local creams and tablets. The local azole drugs work better than the systemic drugs. Side effects are much lesser, and they're just as effective.
Pessaries they come, sir?
Yeah, so the creams and the pessaries, so like the butoconazole type of creams and the miconazole, and these local creams will give better results than giving even systemic nystatin tablets. So they are much better.
So what about the partner treatment here in the Candida?
Now, candidiasis is a little difficult for me to even start, but I will make an attempt for you students. You must know, trichomoniasis, treat the partner. Bacterial vaginosis, no need. Now, fungal diseases like candidiasis, ideally they are not sexually transmitted. We know that very well. It's not under the heading of sexually transmitted diseases, but you know that fungal diseases, they transmit because of proximity. So husband wife will get proximal to each other. We know that. So yes, it's better to treat the husband. It's not that it is a must. So if there is a recurrent candidiasis in a woman, might as well take a charge of treating the husband once, so that the recurrence rates will probably reduce. Maybe there is some reinfection because of the proximity. So that's the problem. Even I think the Harrison books mentions that yes, if the husband is having the infection, might as well treat him as well.
Very right, sir. Very right.
So, what I was trying to tell you, Dr. Sonu, that when I see these patients with white discharge, I take that swab and I put it on the slide, and I look for the clue cells, or I look for the flare, for the
E cells
of
of Candida.
all right. And once I see them, I know it is looking like a case of bacterial vaginosis because of clue cells, or I can see the E cells.
You can see the motile trophozoites.
Or I can see the motile trophozoites. So, a lab, bedside lab test, simple saline prep can give us a diagnosis sometimes. But for candidiasis, most of the times the E cells are not so easily seen. So for that, you say that we should do a proper
we can
culture.
go for culture, sir. And you know that universal fungal culture media is SDA.
The
Over that, Sabrodextrose.
All right, Sabrodextrose. Yes, thank
on
you.
that, the Candida also grows very well.
Okay.
And from that, then you can do again the gram staining, or all other types of staining is also there. Mostly gram staining. In that, easily you can see the E cells and all.
E cells you can see. And the pseudo-hyphae?
Pseudo-hyphae is like constructed in a septate form. They can also be seen up in the culture stuff.
Okay, so that's a lot of information Dr. Sonu has given us. Thank you so much. So I hope you have got a fair amount of idea of how to go about diagnosing a case of candidiasis, bacterial vaginosis, or trichomoniasis. And based on the discussion we had, one punchline I want to just give before going, that bacterial vaginosis and trichomoniasis, BV and TV, they go together, Okay. I don't know whether they're going to like that, but I'm just giving it across. So you can just remember that the bacterial vaginosis and Trichomonas vaginosis, they go hand in hand, and both of them can be treated by metronidazole. And of course, candidiasis, you must say, antifungal drugs. Dr. Sonu, you want to add any take-home message regarding this important topic?
So take home message from my side is regarding the examination questions also. Very high yield topic it is, guys. Lot of questions they come, sir. Every year, like lot of questions are there in every sort of exam.
They must revise this before.
Definitely, sir.
1 week prior exam revision must include this.
Sure, and definitely, like a lot of questions will come from this. And the way sir have presented up the case scenarios with you, because every day sir sees of the patients and all, and along with these particular lab diagnosis stuff which we have discussed up, this topic is mostly cleared off, I suppose, sir.
Yeah,
And,
I think I hope you do not miss out an easy topic like this.
yeah, exactly.
And you know, the biggest mistakes we do sometimes is that the questions
easiest topics.
and the topics which we know well,
we ignore them.
out of sheer confidence, I must say overconfidence, we spoil those answers. So don't do that with this topic at least. I hope our discussion was useful for you. And Dr. Sonu, thank you so much for being
Thank you,
with
sir.
this
Thank you so
discussion.
much. It was lovely.
Yeah. God bless you. Bye-bye.
Thank you so much. Best of luck.